Thank you very much for this very kind invitation. It's to my great honor to be able to present you this keynote lecture on management of neuroendocrine liver metastases. And I would like to thank the association for giving me the opportunity for this presentation. Neuroendocrine tumors have been considered as a rare disease in the past. However, we know nowadays that the incidence of neuroendocrine tumors is steadily rising. These are the data of the third database, and you see very nicely that the incidence of neuroendocrine tumors has increased sevenfold compared to the initial data we had in the 70s. This is not seen in other type of cancer. The incidence of other type of cancer is kind of steady state or even getting less. So the question is, why do we see this really significant incidence rise in neuroendocrine tumor? There is particularly evident that the rise of incidence depends upon the primary tumor location. Patient with lung neuroendocrine tumors, patients with tumor originating from small bowel, or those with rectal neuroendocrine tumors are seen nowadays much more often than this was in the past. Particularly, for example, rectal neuroendocrine tumor, this was a tumor type that was in the past mainly seen in Asia, very often in Japan. But nowadays we see this patient very, very often, very frequently, and some of these patients are diagnosed with the disease, tiny rectal neuroendocrine tumor, at the time of colonoscopy, screening for colonoscopy for colonic cancer. When we are talking about neuroendocrine liver metastasis, we have to keep in mind that the rate of liver metastasis depends significantly on the location of the primary tumor. As you know, neuroendocrine tumors can originate from the lung, from the gastrointestinal tract, from the pancreas, from the ovaries. So it's extremely important that we know where's the primary tumor when we're talking about liver metastasis. Appendiceal neuroendocrine tumors, or those originating from rectum or stomach, nearly never metastasize. It's a different situation in patients who have small bowel, pancreatic, or colonic neuroendocrine tumors. In centers of excellence, we see this patient at the initial time of presentation with approximately 70 to 80% incidence in liver metastasis at the time of initial tumor presentation. So we have to keep in mind that, for example, a patient with appendiceal neuroendocrine tumor, at least a typical neuroendocrine tumor, nearly ever will develop liver metastasis. It's a different situation with those presenting with small bowel or pancreatic neuroendocrine tumors. We have nowadays a panel of different treatment options for these patients with liver metastasis. There has been a lot of improvement over the last 10, 15 years. There is enough evidence that we can estimate what will be the outcome of patient depending upon the type of treatment offered for management of liver metastasis. These are data we have collected in 2014 and also presented at a consensus conference, and you see very clearly the 5-year survival in patients with neuroendocrine tumor is best following surgery, either complete radical surgery or debulking surgery. Liver transplant provides excellent results. And then we have a panel of different non-surgical treatment options with quite remarkable survival when these patients are offered proper treatment. And you will see during my talk, I will point this out, patient selection and treatment selection is really crucial for outcome of this patient. We know that neuroendocrine liver metastases present with 3 different morphologic tumor types. Type 1, single metastasis. Type 2, isolated metastatic bulk accompanied with smaller deposit. And then type 3, disseminated metastatic spread in both liver lobes. Actually, no regular parenchyma seen in this patient. Unfortunately, only around 20 to 30% of patients with neuroendocrine liver metastasis, mainly those type 1 and some of those type 2, are good candidates for surgical resection. So we are really talking about a small number of patients that should be considered as candidates for surgery, either in terms of complete surgical elimination of the disease or debulking. Somatostatin receptor-based PET-CT imaging technology is gold standard in staging of patients with neuroendocrine tumors, and we should have these results in all patients who are considered for surgical treatment. These are results of a patient with extensive hepatic metastasis. You see on this side the lymph node metastasis in the mesentery. This is the tiny primary tumor in the distal ileum. These tumors are very often very tiny. Nevertheless, they have a tendency to metastasize extensively. And this patient also had bone metastasis. Some of them really very, very tiny, and you would never see this bone metastasis on CT scan or MRI. So this type of technology should be nowadays gold standard in managing this patient with neuroendocrine liver metastasis. This is the study that we performed at my previous institution, and this was also done at other institutions. So patients who were diagnosed with neuroendocrine liver metastasis on CT or MRI or both were then considered as candidates for surgery. This patient also then had 68 gallium DOTATOC PET-CT. There are various types of this PET-CT. So this was DOTATOC PET-CT, and you see here very nicely that treatment decision has changed in more than 50% of patients based on the results of the PET-CT. Treatment decision has changed either in terms of changing to non-surgical treatment option or changing our initial surgical strategy. These are the data of single series on resection of neuroendocrine liver metastasis, R0 resection. You see here very nicely the number of patients that are amenable for R0 resection is really not that big. So again, we have really very, very selected subgroup of patients that might be candidates for resection. The overall survival is excellent. Both the 5-year and the 10-year overall survival is excellent. Morbidity, mortality, acceptable and low. However, the problem in this setting is the disease-free survival. Means if we follow this patient for 5 years, even after our 0 or 1 resection, we will see that a large number of patients, if we perform PET-CT in nearly all patients would develop recurrent disease during 5 years. And I like to point out following R0, R1 resection. So these are not palliative surgical procedures. This is radical surgery. What is the problem? Why do patients recur? This is a recent study from US, a large number of patients. This was an international multi-institutional analysis, 339 patients. And you see again very clearly excellent 5-year survival, 74%, excellent 10-year survival, 51%. However, 5-year disease recurrence, 94%. Means at the end of the day, all patients present with recurrent disease. Why is this the case? This very elegant French study, now just most recently confirmed by another group, showed very, very nicely that we are dealing with micrometastasis, not detectable with the technology we have available nowadays. So what was done in this study? The pathologist has investigated, has examined the specimen resected, and their results were compared with the results of preoperative imaging, ultrasound, CT scan, MRI. At that time, we haven't had PET-CT yet. It was a traditional somatostatin receptor scintigraphy, and the intraoperative findings, means what was found by the surgeon, potentially combined with intraoperative ultrasound. And you see very nicely, the surgeon identified around 8 metastases. On historical somatostatin receptor scintigraphy, around 3 were seen, MRI 8, PET CT scan around 5. However, ultrasound around 5, 6. However, the pathologist found in median 13 metastases, means much more than evident on preoperative imaging or on intraoperative exploration of the liver. So at the end of the day, we are resecting the top of the iceberg and leaving liver parenchyma with numerous micrometastases behind. This is the result of a study, again from US, comparing different type of treatment for patients with neuroendocrine liver metastases. You see quite a large number of patients, 649 patients with liver metastases. However, less than 10%, 58 patients were amenable for liver resection, and they have compared this data with other type of treatments. They have shown, not really surprising, hepatic resection is the best. However, we have to be here very careful. For sure, a patient who was identified as a candidate for hepatic resection is not comparable with a patient who got systemic therapy or who got just chemoembolization. So again, there is evidence that surgery is effective. However, no prospective randomized trial comparing surgery with different type of treatment options that we can offer to our patient. Liver metastasis is generally, a liver transplantation for neuroendocrine liver metastasis is a generally accepted treatment option. It's, at the end of the day, the only indication for transplantation in secondary liver disease. You see that we have a lot of data, some of them quite old, historical data. These are single center series on outcome of liver transplantation. Overall survival, not bad. However, the same problem, many of these patients develop recurrent disease. When we are evaluating patients or candidates for liver transplantation, we have to be extremely cautious. We have to really go for a very, very strict selection. There have been some selection criteria identified, however, not yet properly validated. For sure, patients with poorly differentiated or high-grade tumors are not good candidates. Tumors with non-portal venous drainage, for example, lung neuroendocrine tumors, should not be considered for liver transplant. And then an ongoing discussion, the percentage of liver involvement. Should we transplant those with low volume or those with high volume? And I will show you data on this in a second. Extrahepatic metastasis, clear exclusion criterion for resection, and also carcinoid heart disease, as in this patient. We have to be very, very careful. Patients with carcinoid heart disease are not candidates for liver transplantation or can only get liver transplantation after they had surgery for cardiac, for carcinoid heart disease. These are the data of a large European data or series registry study on 230 patients. You see very nicely in this study, 5-year overall survival, 52%, again, retrospective data collection, comparable, at least at that time, to HCC, disease-free survival around 30%. The group has identified 3 risk factors: hepatomegaly, resection in addition to liver transplantation, and age more than 45 years, means patients with theoretically 2 or 3 of these factors are not good candidates compared to those who do not express this type of phenotype. So again, extremely important to properly select the patient. This is a most recent study on liver transplantation in neuroendocrine tumors, remarkable results. You see 5 and 10 years overall survival, 97% and 88% compared to 50% and 22% in patients who were not transplanted. Means in this study they prospectively observe a group of patients who had a transplantation with those who were observed only. Again, excellent results with regard to disease-free survival. And if you compare this data, 5-year disease-free survival, 89% in this study, and disease-free survival of resected patient, just 5%. So at the end of the day, one could say we should not resect this patient at all. We should go straight forward for liver transplantation in case, but I'm just provocatively saying this, in case there would be enough organs for this type of indication. Now moving from the surgical part of the management pathway to the non-surgical one, patients with neuroendocrine liver metastases have in general very hypervascular nodules in the liver in the presence of healthy underlying liver parenchyma. So we have a different situation. Patient with HCC have very often liver cirrhosis. Patients with colorectal liver metastases are sometimes heavily pretreated with chemotherapy and might have some damage to the parenchyma. It's a different situation in neuroendocrine tumors. We have multiple hypervascular nodules in the liver, normal liver, more or less good general condition of this patient. So these patients are, at the end of the day, ideal candidates, if they are not resectable, for percutaneous angiographic liver-directed treatment, and selective internal radiotherapy has emerged to a very promising situation or treatment option in this situation. So these are the data of one of our patient. You see multifocal disease in the liver on MRI, confirmed on 68 gallium dotatate PET-CT. You see here very nicely much more disease on PET-CT than seen on MRI. Chromogranin, the typical tumor marker, sky high, more than 10,000. So this patient went for selective internal radio treatment, and this is the results 2 months post 2-stage treatment. In most of these patients, since they have bilobar disease, you should go for 2-stage treatment, not for 1 liver whole treatment. Excellent outcome, nearly complete response. You see very, very faintly here a single lesion in segment 4, confirmed on 68 gallium dotatate PET-CT. Chromogranin dropped significantly down to 786. So this patient went then for radiofrequency ablation of this single metastasis and is at least at this stage macroscopically tumor-free, although chromogranin as a tumor marker indicates that there is still disease persistence. These are data from the literature on selective internal radiotherapy for neuroendocrine liver metastasis. We have quite a large number of series nowadays. You see excellent 3-year overall survival, around 77%, in some series down to 40%, and also very good progression-free survival of around 44 to 50%. Now, patient with less extensive hepatic tumor burden can be candidates for radiofrequency ablation. The predominant lesion should not exceed the size of 5 centimeters, and we should achieve a post-ablation margin of at least 1 centimeter. Overall survival, 37 to 50%. Median disease-free survival, however, only around a year. So a good option for selected patient, but we have to be aware that this patient will progress. Now, we have, since a couple of years, prospective randomized trials in this setting. Unfortunately, not surgical trials. They are all non-surgical, but still, for the first time, we have prospective randomized trial. This is the so-called NETA trial comparing 177 lutetium dotatate, means radionucleotide treatment with lanreotide, with somatostatin analog in patient with mid-gut-net. Actually, all of them had liver metastasis, and you see very nicely the treatment with lutetium dotatate provides much better results than somatostatin analogs, only with regard to overall survival and progression-free survival. These are results of one of our patients with metastasized insulinoma. You see here on gallium PET extensive disease in the liver, tiny primary in the pancreas, extensive disease in the bone. This is after 4 cycles. This is around 1 year treatment, 3 months in between the cycles. Already excellent response. And here after 6 cycles, nearly no disease anymore. This is physiological uptake in the kidney, urine, bladder, so excellent results. And in this patient, we went then for debulking since he responded extremely well to treatment. Other trials comparing somatostatin analogs with placebo. The first trial published 2009, very nicely shown octreotide has better outcome than placebo with regard to progression-free survival, around 60 months versus 6 months. Comparable results in a more recent trial, clarinet, lanreotide, compared to placebo, again, significant better progression-free survival compared to placebo in the treatment arm. All these studies, everolimus also shows very nice progression-free survival improvement compared to placebo, and sunitinib, the same results. However, in none of the studies there was any improvement in overall survival. Means we can achieve a prolongation of progression-free survival with this type of treatment, but at least at this stage, we don't have a tool in our hand apart from surgery, apart from liver transplant, that could achieve improvement of overall survival. So how do we implement all this new information we have, all this biochemical data, imaging results, how we implement this in management of patients with neuroendocrine metastases? First of all, once the diagnosis of a neuroendocrine tumor is established on biopsy, biochemistry, on imaging, nowadays we use the term neuroendocrine neoplasia, no more neuroendocrine tumor, so the new term is neuroendocrine neoplasia. It is extremely important to clarify the grade of the disease. Is it a high-grade disease, poorly differentiated tumor, very aggressive? This is for sure not a candidate for liver resection or any surgical treatment. These would be candidates for chemotherapy. Different stories on this side, low-grade or intermediate-grade, well-differentiated tumor, either with liver metastasis only or liver metastasis with extrahepatic disease. Here we have a large number of different treatment options based on the type of metastasis, based on the presentation of the disease in the liver. Now, we have all this, a large number of treatment options, but we still don't know yet what should be offered to a single specific patient. So as in oncology, nowadays in every field, we are also aiming to offer precision treatment in patients with neuroendocrine tumors. There's absolute need for novel omics-based tumor markers like microRNA, circulating tumor cells, gene transcripts, metabolomics, radiomics, epigenetics. All these can theoretically serve as novel tumor marker, not only in neuroendocrine tumors, also in other. We are working on this. There are promising results achieved in the laboratory setting, nothing yet really in the clinic. And the idea for the future would be that these omic results would help us, first of all, to better stratify what type of treatment should a patient get. Should it be radiofrequency ablation? Should it be SERT? Should it be peptide receptor radio treatment? So what type of treatment? Then to monitor response to treatment, to identify those that do not respond very well earlier than nowadays on imaging. Nowadays, we perform imaging normally every 3 to 6 months during the patient journey. So if we would have a tool, a liquid biopsy where we could take blood or urine or stool, for example, every couple of weeks, this would be an extreme improvement in management of this patient, and then decide, should we continue with the treatment or do we have to switch to other treatment options? Again, the candidates for resection, should a patient go straight forward to liver resection or straight forward to transplantation, or should we offer him or her any neoadjuvant treatment? Should we offer adjuvant treatment? So this is all what we expect to be able to offer our patient in the future. However, I think it's still a long way to implement the results we have nowadays in the lab into the clinical setting with an aim to improve the outcome of management of patient, not only with neuroendocrine liver metastasis, but with a neuroendocrine disease. Thank you very much.
We have 1 or 2 minutes for questions. If there's any questions from the floor, please state your name and where you're from and your question.
Andrea, Dr. Jagannath from Mumbai. Patient with the bilobar liver metastasis alone and a G1 category, based on the NETA data, would you offer them PRRT or would you offer them liver transplantation?
That's a very, very good question. I would turn it around. Should this patient have PRT first and then liver transplantation? There are some data. I have to stress, however, PRT is not officially approved in the neoadjuvant setting. It's also not approved in adjuvant setting, but centers are offering already patient PRT in terms of neoadjuvant or adjuvant treatment. So most likely, but this is again, no level of evidence, extremely low. Most likely the patient would benefit first from PRT to destroy the micro disease, the circulating tumor cells that we don't see yet, and go then for liver transplant or liver resection. We have one single patient, I think we discussed about this patient already as we met in India, who had PRT and intestinal transplantation, multivascular intestinal transplantation for metastasis, small bowel neuroendocrine tumor, metastasis to the mesentery. And he has excellent outcome, and it could be that this combination is something we should strive for.
Yeah.
Thank you.
One more quick question.
Thanks, Andrea, for that brilliant overview. My question is, you showed us that 94% will have recurrence, even if we think that we have done a curative resection. Now, my question is, do we have adjuvant data? Are we performing studies? If not, what would you do with a patient? Or do we have data that would support additional treatment after potential curative resection?
This is an excellent question, and this is really an unmet need in the field. And as you know, at any major consensus conference meeting, whatever, we are always discussing there's need for adjuvant studies. There's no adjuvant study. There's one adjuvant study planned, somatostatin analogs post-liver resection, and I'm aware of one running study in France, PRT post-liver resection, but the results are not available yet. So most likely, all patients should have adjuvant treatment, and again, I know that several centers offer this patient somatostatin analogs after liver resection. Also, not really approved indication, but they are offering somatostatin analogs. We know these are drugs with actually no side effects, so it is ethically acceptable to go this way, but I think this is something that we really have to sort out in the future. I think it's the only oncological disorder where we have no neoadjuvant and no adjuvant concepts, and at the same time, we know that nearly everyone recurs after resection.
Just because we're running into the next session, can you ask Dr. Frilling your question after the session? Thank you very much for a great talk.
Thank you.